It doesn't have to always be an hour. Do some practical stuff too. So many, we get the nurses into what they want to hear about, what they feel like they need education.
We could do like a staff meeting every month there.
That's a great idea because I know Sherry has asked for service is monitored.
Yeah.
And I think we can easily do a hypothermia update is monitored. Now some of the CRNAs and talk about how it is like mechanically and how you see it.
So maybe tomorrow you and I can right?
Yeah.
Yep. I will. Let's look at our schedule. We'll set it up for this month.
Okay.
If we can. Or even beginning of next month.
Certainly we can do it next month.
Okay.
I might be able to do the first one that last week in August.
Okay.
Like the 22nd or 26th or something like there.
Okay.
But certainly in September if we can't do August.
Okay.
Because I was thinking we can do hypothermia, we can do a little update on sepsis. We can do something less exciting. That might be a couple updates. Or we can do something less exciting like infection prevention and central lines, all that kind of lines of dressings. I know Mo would like to do one on volunteers in anticipation that we're going to have some volunteers.
Yep. We have a series. We have things set up for balloon pumps.
Do ya?
It's
Set up?
September, right?
I haven't set up.
Very good.
Serious? Good.
You should probably know about it though.
I should know.
Okay, I'll email it to you. I just thought of that when I looked at you.
Yeah, that'd be good.
Okay, I'll email it to you.
I just wasn't sure how to pack your It's hard to say what's behind this.
I wonder if should we leave the back door
That's what I thought.
Might not ever made it to Norway.
Welcome, everybody, to our first Grand Nursing Forum. And what's really neat is I'm seeing some other disciplines represented here today. I think that's one of the beauties of this program is going to be that we're able to have some knowledge transfer between members of our own patient care team. And I want to thank Dr. Yeoman for being our first speaker for our Grand Nursing Forums. And I also want to thank Susan for setting this program up. I think it's going to be an exciting program. We're going to try and have these monthly. And so you should be seeing some marketing on exactly what's coming up in the future, or very near future. Just a reminder, for those of you seeking CEs today, you need to sign in on the sign-in sheet. If you didn't do so already, you need to do that before you leave today. The Montana Board of Nursing has approved one contact hour for today's presentation. And our intention is to make this a web-based program also. Following this particular live event, I'm going to spend a little bit of time kind of getting that right sized and into the electronic version, if you will, so that if you miss these in the future, or if you have colleagues that have questions after today's event, you can let them know that we're going to be having these online for you to do self-study also. Doesn't mean you guys can do it again for another credit hour. That's for today's live class, but others will have an opportunity to take advantage of this education also. I need to acknowledge also that Dr. Yeoman's and the Planning Committee, we have nothing to disclose. There's no commercial support for this particular education activity. These disclosures are part of your handout that you received on the way in. Also, if you would provide some comments and some scores on the evaluation form, that helps us with these programs moving forward, and also provide Dr. Yeoman some unique feedback also. You can leave those at your place or put them up in this corner. I will have some certificates for you all that I'll provide to you at the end of today's session. Any questions at all before I turn it over to Dr. Yeoman? Okay.
And I'll put in a plug for the feedback form. We want suggestions on topics that you guys want to hear about. Okay, so make sure you put in those hot and burning things that you've been wanting to ask that you haven't asked anybody about.
Okay. Well, that'll go ahead and turn it over to you, Doctor.
Okay. Can you guys hear me okay? All right. So I got asked to talk about hepatic encephalopathy, and I think this is because one day we had a bunch of liver patients on the 3rd floor, and I asked a couple nurses, well, do they have asterixis? And nobody seemed to know what that was. So now we're talking about it. So very briefly, so hepatic encephalopathy, it's always good to get the baseline down. So let's start with a definition. It's the same thing as portosystemic encephalopathy, which just means that it's because of a raised pressure in the portal system going through the liver. It is a reversible syndrome of neuropsychiatric abnormalities seen in patients with liver dysfunction. And technically, you need to have pretty profound liver dysfunction. So it's a diagnosis of exclusion. Obviously, you need to rule out the unrelated neurologic things that can look a lot like hepatic encephalopathy, and so I've put just a couple up there. We see a lot of really bad hyponatremia. If your sodium's 115, you look pretty similar to somebody who has pretty bad encephalopathy. Also, don't ever forget the head bleed. We all get faked out once in a while. And it actually describes a series of clinical entities. So it can be truly only a metabolic process and a buildup of toxic metabolites inside the blood-brain barrier, but it can also be accompanied by greater than expected brain atrophy or greater than expected brain edema, or it could be any combination of these things. And by the way, I want you guys to stop and ask me questions or jump in with things whenever you want to say something. Okay, so just in background, who develops hepatic encephalopathy? You pretty much have to have functionally end-stage liver disease in order to get there. So you need to have, end-stage liver disease defined as bridging fibrosis on a liver biopsy, a small nodular liver on imaging, and less than 10% synthetic function left. People can also have acute hepatic failure, whether it's fulminant or non-fulminant, and you think about like your Tylenol overdoses there, or the young woman who has autoimmune hepatitis that just goes out of control and flares up. And then obviously the well-populated in Butte or well-represented in Butte sample are the alcoholic liver disease folks. Okay, so just as a reminder, manifestations of end-stage liver disease, just so we're on the same page. So usually people, you need to see the pretty decompensated people before they develop a lot of encephalopathy. So they have muscle wasting. Where do you see their muscle wasting? Anyone? Yeah, so like in their extremities, in their temples, in their neck. Jaundice and sclerolicterus, ascites, palmarothema. What are spiders? Anyone know what? It's those little clusters of dilated veins. They're usually on the chest and the upper arms. They look like a little nest, a spider on there. And if you push on them, they blanch and then they fill right back up. They're like little hemangiomas. And I didn't put on here, but you're right. Those dilated umbilical veins on the belly can be part of that. What's feeder hepaticus? It's the dead breath smell that some liver patients have. Every nurse, every therapist who's had to lean in close knows that one, right? And then you should also see problems with liver synthetic function. So just as a reminder, enzymes of liver function are your protein, your bilirubin, and your albumin. These are all proteins the liver produces. AST and ALT elevation, transaminitis, is a sign of liver inflammation. So when we talk about liver function, we talk about what's your protein, what's your albumin. So, example, end-stage liver disease, bad dilated veins. Yeah, she's the poster child for the USC pediatric transplant program list. Okay, so let's talk about why this develops. There's a lot of hand waving. There are a lot of neurobiologists out there raising rats and then feeding them liver toxic chemicals and then doing studies on them. Yes, seriously, there's some nasty stuff out there. But the main hypothesis is that when you develop such severe liver dysfunction, you lose the function of the liver to filter all those toxins out of the bloodstream that the liver normally does. And specifically, you're losing the ability to filter out all the gut toxins. So typical toxins that we talk about that we know cause problems when they get into the brain are ammonia, mercaptans, short-chain fatty acids. There's one called oxindol. And there's a bunch of other aromatic amino acids. These are like 5 of several hundred compounds that can cause problems. So all patients with end-stage liver disease have a decreased ability to filter those gut-produced neurotoxins. They all have increased permeability of the blood-brain barrier. And along with increased permeability, for whatever reason, they all decide to make more proteins that like to carry amino acids and short-chain fatty acids across the blood-brain barrier. And then they all have brain cell swelling at baseline. And that has to do with the free water misregulation. And then lastly, they all are not so good at utilizing their cerebral glucose. So they all have impaired metabolism to start with. And this is kind of where they're starting, and then it goes from there. So let's take ammonia as an example, because that's the toxin that we can quantify and that it's best studied. So ammonia is produced by the gut. It's produced by cells in the small intestine that are breaking down glutamine from protein. It's also produced by bacteria that live in your colon as they break down urea and other byproducts when they're metabolizing the stuff that's lower down in your system. So I think it's pretty remarkable that a normal liver filters essentially all of this ammonia out of the gut circulation. So all that stuff dumps into the mesenteric veins, goes back into the portal vein, gets spread out through the liver, which is like a big drain field, and the hepatocytes chew it all up and they turn it all back into glutamine and urea so that they can be excreted or reused. But in somebody with end-stage liver disease, they only have less than 10% normal hepatocyte function left, so there's going to be some ammonia that's missed. They just can't do it all. In addition, we all know that people with liver disease develop shunting issues, right? They get esophageal varices, gastric varices, they get rectal varices that can recannulate their umbilical vein. So there's a whole subset of portal blood that gets shunted around the liver, never goes through the liver to start with, and gets dumped back into the inferior vena cava. None of that blood's been filtered. So all of these people at baseline are floating around with high levels of ammonia in their bloodstream. Okay, other organs in the body that make or get rid of ammonia. Your kidneys are your second biggest maker or excreter of ammonia. And an interesting thing here, and I think we don't appreciate it well, is that so your kidneys will excrete your ammonia, they'll make urea, it'll get peed out in an acidic environment. But if the environment inside the kidney is alkaline, they will actually break down urea into ammonia, and then it's an alkaline environment, so the ammonia doesn't get that extra hydrogen ion to become ammonium, and the ammonia diffuses back into the bloodstream. So how many end-stage liver disease patients do we have who come in hypokalemic?
They all do, right?
Right, and how many of them have a metabolic alkalosis because of their CNS issues? So in that situation, if you don't correct that hypokalemia because it's an ammonia hydrogen ion co-transporter, you will actually cause your kidneys to make more ammonia and dump it into your bloodstream. The other issue for end-stage liver disease patients goes back to the fact that they have a lot of skeletal muscle wasting. Our skeletal muscles can actually metabolize a lot of ammonia out of your bloodstream, but if your muscle mass is really poor, you're not going to be able to do that even as a salvage mechanism. Okay, so this is about as technical as the talk is going to get, so bear with me for 2 more slides and then we'll go back to clinical stuff. So, okay, what does all this excess ammonia and these other neurotoxins do that are floating around in the bloodstream? Well, they cross that blood-brain barrier that's more permeable than it would normally be, and they do a few different things. So basically, they get sucked right into the brain cells. when they get inside the brain cell, the only thing the brain cell can do with ammonia is convert it back to glutamate. Well, then it gets stuck in the cell because it can't move glutamate out of the cell. So it puts this protein load inside the cell, which sucks water into the cell along with the protein, and your cells swell. So you get cerebral edema. In the worst case situation, you get an increased intracerebral pressure. When the cells swell like that, they also get electrolyte derangement, so they don't conduct signals like they should. So your cellular transmission of your neurosignaling is off. And then it causes RNA oxidation, so the RNA won't make the proteins that lay down memory. So you have short-term memory loss, and you're forgetful. And there's also a whole subset of studies looking at ammonia and other amino acids that they basically bind to GABA receptors, or they bind to receptors like GABA receptors, and they make the brain think that you've just taken a bunch of Ativan, which is where a GABA receptor binds, so they make people sleepy. So basically all this ammonia is causing cerebral edema. It's reducing the ability to fire off neurons in a coordinated manner, so you get discoordinated skeletal muscle responses. You have short-term memory losses because you can't do the memory pathway synthesis like you normally would. And then you're sedated because your brain thinks you're stoned on benzos. It's kind of like the perfect catch-all, isn't it? All right, so let's go back and think about causes. So going back to that definition, it's a reversible syndrome of neuropsych abnormality. So that implies that people don't just suddenly fall off the deep end most of the time. They usually something had to happen to them in order for it to get there. Does that make sense? So if the problem is circulating levels of protein breakdown products, amino acids, ammonia, what do you guys think about possibilities for things that might cause increases in ammonia load or protein load in your system? Throw out a few answers. Everyone's being shy now, making you talk.
GI bleeds.
Yeah, so GI bleed is great. So what does the GI bleed do? It basically puts a big protein load in your gut, because blood is an awesome protein, right? The heme ring can be broken down into a lot of protein. How about anything else? What about if you get infected? So then your total body protein load goes up because you have all these really metabolically active white blood cells that are dumping out urea and protein breakdown products in the process of trying to fight off that infection. So GI bleed, so infection. What about stuff that functionally increases protein concentration? Yeah, so what if and that can either be because you got sick and something organic happened, like you got the stomach flu and so you had horrible diarrhea. Or it could be from something that we do to folks with end-stage liver disease. And what kind of drugs do we give them all? Yeah, so we give them diuretics, right, to try to shrink their ascites, so we can iatrogenically do this to people. We also give them lactulose, which we'll talk about later, to give them diarrhea, which doesn't help the situation. And then so we don't forget that metabolic issue. And then the other issue is a blockage of flow. So this table, I thought I stole it from Up to Date because I thought it was really good and you could actually see it. Can you guys kind of read it from the back? Not really.
At least it's easy for me.
All right, so they're basically looking at things that precipitate hepatic encephalopathy. And so on the top section is drugs, so things that stone you or things that compete for those GABA receptors, so benzos, narcotics, alcohol, all our favorite frequent flyer problems here in Butte. And then there's things that increase ammonia production or absorption or entry, so that's where we're talking about the GI bleeding, the infection, constipation, big issue, an underappreciated issue in hepatic encephalopathy folks. So all your neural responses slow down in end-stage liver disease, so your gut doesn't work as well either. So if you have all of this waste product just sitting there for these bacteria to chew up and it doesn't go anywhere for 2 days, those bacteria are going to go to town and make more urea, more ammonia, than they would if the intestinal transit were faster. Diuretics, large volume paracentesis. So then the stuff that can cause occlusion is really portal vein or hepatic vein thrombosis. and it just causes a standing column of blood. And then every once in a while, just hepatocellular carcinoma can worsen encephalopathy. Kind of have to rule everything else out first. Okay, so how do you diagnose it? So it's this collection of neuropsychiatric behavioral things. So I'm going to refer you guys to page 2 of the handout, which is this color graph that you should have all picked up. I copied it for you. Again, I stole it from actually Lippincott, Wilkins, and Williams, because I think it's probably the best single piece of paper that has everything on it that can happen. So if you notice, so hepatic encephalopathy is graded in stages, which we'll talk about. Normal is on the left, stage 0. Stage 4 on the right is most affected, biggest buildup of toxins. So one of the very first things that happens is that people get sleep pattern disturbances, and they either have horrible insomnia or they just can't stop sleeping at all. They have a hard time waking up. So then they get progressive neurologic signs, and these are kind of listed in order of progression of encephalopathy. So what's bradykinesia? Anybody in the PT world, throw it out. Yeah, so just slow responses, right? What's asterixis? Ooh, does anybody know? Okay, my movie didn't work. You're exactly right. So you have to make do with one picture. But asterixis is a liver flap. And so you get the person to hold their arms out, elbows straight, hands dorsiflexed, and they do this, and it's unconscious.
They can't control it.
Yeah, I mean, they can't control it. It's spontaneous. And it can go from just very occasional and very subtle to really, really pronounced. That's actually one of the most sensitive signs of hepatic encephalopathy. So then going in progression, the worse your encephalopathy gets, hyperreflexia, clonus, which is sort of like that end of hyperreflexia where you just have sustained beating whenever you put pressure on something, dorsiflexion, decerebrate posturing. And I thought it was interesting that up to 40% of patients, and depending on what study you look at, actually have a focal neurologic sign. And so these are people who had like right arm weakness and slurred speech, and people thought they'd had a stroke. You know, how many people do we see like that? Thinking of our frequent flyers, right? All right, so they also have behavioral changes, and that's again on the same graph. And usually people start out in stage 1, they're almost totally normal, they can tell you where they are, they're alert and oriented ×3, but they're a little bit off. And they're either a little more up than they normally are, or they're a little more down than irritable than they normally are. And we might not notice it, but it's usually their spouse or their family that says, this is not normal. So then in stage 2, that progresses and it gets more pronounced. And sometimes they flip and become exactly the opposite. And then they gradually get to totally inappropriate, bizarre, like schizophrenic kind of activity until they go into a coma.
Does that take a long time? Awesome.
So that's actually a really good question. And so we've had a couple people on our unit, for example, who accumulate so many toxins so quick that maybe at 8 in the morning they're stage 1 and they're just a little bit off. Mr. A is who I'm thinking of, and their wife says well, he's pretty good, but he's a little bit off. And then by noon, you have to, sternal rub them to get him to make a response. That sort of skipped all of the I got really irritable, and then I got weird, and then I tried to poop on the floor or do whatever sort of bizarre thing I wanted to do, and I just went straight to I'm going to go comatose now. So it can be slow or it can be quick. So, and they also have neurocognitive deficits, and actually the single most sensitive indicator of hepatic encephalopathy is this number connection test. And I'm going to make you all do one, which is the test on page 3, but we'll do it a little later.
Oh, did everyone get one?
Yeah. And so then they oftentimes have the classic lab findings, right? So so that was asterixis. So number connection test. Okay, I'm going to explain the principle, and then we'll do it at the end of the lecture. But basically, you guys all have to hand out, it's all these circles, 1 to 25. The idea is you have the patient write and sign their name. You do an initial grade based on their mental status that you put at the top of the test in the corner, where you think they're going to shake out in terms of what stage encephalopathy they are. So if they just have a tiny change in their mental status, and they only have a tiny bit of liver flat, maybe you're going to say they're stage 1, you think. If they have obvious changes in their mental status, they have a lot of flat, maybe you think they're stage 2. And then you have them do this test. And what you do is you tell them to start by putting their pencil on 1, and they have to connect all the numbers in ascending order as fast as they can. And if they can draw through numbers, they can go around numbers, but they have to go in order. And if they screw up and they go from 6 to 8, they have to go back to 6 and start over again. So you have to be able to do this in less than 30 seconds in order to not be encephalopathic. I can tell you on a good day it takes me like 22 to do one of these. So you can imagine. So we're going to do this, and it's actually quite sensitive then for the stages of encephalopathy. Okay, so let's go back and let's talk about ammonia, and then we'll do this number connection test as the fun part at the end. So there's lots of hullabaloo about ammonia, and nurses oftentimes always, we get lots of phone calls, hey, do you want an ammonia level today to see where the patient's at? So how accurate is it? Well, it's only elevated in 60 to 80% of people who have hepatic encephalopathy. So hepatic encephalopathy is a clinical diagnosis based on what they look like, what their reflexes are doing. If they happen to be encephalopathic and their ammonia's up, you can say, hey, it is hepatic encephalopathy. Just be aware it's a really insensitive test, so it totally depends on how the blood was gathered. Technically, we're supposed to be doing arterial sticks and putting them on ice immediately and then running them down to the lab and processing them immediately. And that's far more accurate than a venous sample. And if you put a tourniquet on someone's hand, that can raise your level by 30% on their arm, because you localize that standing column of blood. And the studies say that, so if your ammonia is within 2-fold of normal, and you catch it on day 1 and say your ammonia is 60, and you catch it on day 2 and the ammonia is 80, and the upper limit of your test that's normal is 45, so you're still within that 2-fold increase, and the patient's more encephalopathic on day 2, okay, that probably correlates. But if their ammonia is 300 and they're fairly perky, that doesn't tell you anything. It tells you they're probably making ammonia from some other source. So not a reliable test. You shouldn't base your diagnosis on it. And the reason being, these are some of the other things that can raise your ammonia level in your bloodstream. So there's some pretty common stuff on there, right? Like GI bleeding will give people elevated ammonia, right, from the blood breakdown. Turns into bilirubin. Shock. Somebody who's gone into low-level rhabdo because they were powerlifting and then went out and ran when it was 100 degrees out, had too much DHEA and went on a bender, Please notice that barbiturates, narcotics, diuretics, and alcohol, as well as valproic acid, can all raise your ammonia level. Lots of people we see on a regular basis. Okay, so the take-home principles for ammonia. This is the Acute Liver Failure 2009 Working Group's formal consensus statement on what do we do with blood ammonia levels. So it's not a useful screening test for hepatic encephalopathy because it's not that accurate. Hepatic encephalopathy is a clinical diagnosis. And then again, if you have hepatic encephalopathy and you know your ammonia level always rises when you're more encephalopathic, sometimes you can check the ammonia later after you've been receiving therapy as the mental status improves to see how much the ammonia drops. But it's only useful so that you know with that patient in the future, okay, when my patient's ammonia is 40, this is what their mental status generally looks like. Does that make sense? But it's different for every single patient. So your 40 may not look like my 40. Okay. So again, this is that grading thing again. So we start out with the most sensitive finding is just sleep disturbance, but that could be all of us in the room for various reasons. So you can't take that in and of itself. So then again, stage 1, really the asterixis, and you're either a little more up or a little more down than normal, and then it kind of progresses from there. Stage 4, by definition, is essentially semi-comatose or comatose. And a point here, if you look on the other sheet with the 4 colored graphs and you look at the physical exam findings, people start getting increased intracerebral pressure at like late stage 3, early stage 4. So all the stuff you see with people with increased ICP, so they get hypertonous, they get hypertonic, they get big dilated pupils, all that stuff happens. They decorticate or they decerebrate posture. That's all consistent with bad encephalopathy. And that was the bunny shot one that I gave you. Okay, so how do you treat it? So twofold. You gotta treat the underlying cause. I thought it was interesting that 70 to 80% of people with an acute flare of their hepatic encephalopathy will get mostly better on their own if you don't give them anything to do with the ammonia and you just treat your underlying situation. So you fix their dehydration or you stop their GI bleed. Gotta treat that hypokalemia so the kidneys don't keep making ammonia. And then there's really only 2 modes of therapy, right? There's therapy that increases the GI clearance of ammonia, i.e. we make you poop. And then there are antibiotics that are poorly absorbed into the system, but they decrease the amount of gut fluorine, so they decrease the amount of ammonia production that bacteria in the large intestine will do. These are all poorly evidence-based. So it's important to know that lactulose and a couple antibiotics have been proven to improve quality of life and cognitive function, but they don't necessarily do anything for mortality at all, unless you're in late stage 3 or stage 4 encephalopathy and you're acutely reversing it so that you don't herniate. Okay, so lactulose, it's the gold standard such as it is, or maybe we should say it's the brown standard. So it is better than placebo. There was one trial with 40 patients that showed it was better than placebo. 70 to 80% of people will improve when treated with lactulose alone. But that leaves a pretty big gap who don't improve when they get their lactulose, right? I mean, I was kind of surprised about that because we harp over the lactulose. Make them poop. And then they also did a study that was pretty decent that says, yes, it does decrease the hepatic encephalopathy recurrence rate by about 80% over 14 months. Decrease the hepatic encephalopathy recurrence rate significantly in 80% of people over 14 months. So mechanisms of action. Okay, so basically think lactose intolerance. So what you're doing is you're giving somebody a compound that's basically like lactose that they can't absorb. So you're inducing all the symptoms of lactose intolerance. So it's a disaccharide. It gets broken down by the bacteria in the gut. So you can't absorb it, so it passes through the small intestine. Gets broken down by the bacteria in the gut to these short-chain fatty acids like lactic acid that then lower the pH in the gut and cause that ammonia, the NH3, that's solubilizable and can diffuse across the membrane to get an extra hydrogen ion, so it gets trapped in the gut and becomes ammonium. So then you have to poop it out. So I've always wondered if you could actually light somebody's fart on fire. I was getting a lot of lactulose, but it is what it is. It does a few other things. So it's a laxative, it helps with that chronic constipation, it moves stuff through. And I thought it was interesting that it actually, because it creates an acidic environment, it will cause your gut to be recolonized with lactobacillus, which doesn't actually break down urea or produce ammonia. So it helps you over time if you stay on it. It's sort of like drinking cranberry juice to recolonize your vagina in women who have recurrent bacterial vaginosis. Okay, so the evidence-based dosing. For acute decompensation, 45 to 180 grams a day is what the studies looked at, with the goal of 4 to 6 loose stools or as needed until mental status clears. There's some feeling that in a patient who's got a rectal tube in, that's 1 to 2.5, 1 to 3 liters of stool output a day. And then the maintenance dosing would be 45 to 90 grams separated to get 2 to 3 soft stools. And then there's always the enema. So enemas were actually proven to be more effective than oral lactulose. But who wants to wants to administer the 1 to 3 liters of the enema, much less receive it a day? All right, so again, side effects, think lactose intolerance. It makes you cramp, it makes you bloated, it gives you flatulence, gives you diarrhea. And the standing consensus statement is that if you're limited by the severity of your diarrhea and your metabolic or volume issues and you can't get enough clearance of your encephalopathy, then you augment with antibiotics, but you don't replace the lactulose with antibiotics. So the antibiotic of choice, rifaximin, which we do have, which is sort of like a rifampin. It's poorly absorbed by the gut, got good gram-negative coverage, if I'm speaking correctly. Fellow pharmacy types weigh in here. Not spreading lies.
Can it be given IV?
No,
I think it's only oral, isn't it?
it doesn't work because you
Because-
give it in the gut because it doesn't get absorbed. If you give it IV,
So you would have to
do
do
what
it
it's supposed to
to
do.
dissolve it into a tube.
Yeah.
Right. It's like oral vancomycin and C. diff. Yeah, same theory. So again, similar efficacy to lactulose in the total of 5 trials that were done on it. Better tolerated because there's less diarrhea, so people take it with better compliance. It is more effective than placebo, but it's pretty expensive. And what do you guys think a month of rifaximin runs? If I were going to put you, it's like several $100s,
Yeah,
isn't
I think
it?
it's even when we use it in the hospital for a week or so, it's expensive.
So again, and largely because of the cost issues, the acute hepatic failure, liver failure study group's consensus statement is that you should just add it to lactulose rather than replace lactulose with it, except in special circumstances. Okay, so we all know about neomycin, those of us who've been around long enough. Interestingly, there have been about 4 studies that show that there is no difference in giving people neomycin either orally or via enema compared to placebo in terms of outcomes of resolution of encephalopathy. But they did kill off some people's kidneys and eardrums. So we generally don't use it so much anymore. There have been some studies using oral vanco, same for like C. diff dosing, and oral flagyl as in C. diff dosing. The longest any of those studies lasted was a 2-week stretch. Actually, I think the vanco one was 4 weeks. They're not often used. Nobody really knows if they would work long term. And then there's all this experimental stuff. So there's amino acid infusions that may or may not help. And interestingly, acarbose, which is a diabetes med, so they were using it in a diabetes trial, and they noticed that all of their diabetics who also happen to have end-stage liver disease, or many of their diabetics who had end-stage liver disease, had improvement in their hepatic encephalopathy. But nobody's done the study. And then there's a whole bunch of other stuff out there. Okay, dietary protein restrictions. So this is actually kind of controversial. So the party line as of even 4 years ago was end-stage liver disease folks should be on a protein-restricted diet. Well, there have since been a handful of studies that are pretty decently done that suggest that people with acute hepatic encephalopathy who don't have significant chronic hepatic encephalopathy, so this is the person who does well most of the time and then bang, they go really bad, that is not the person that you need to protein restrict. And in fact, there was this quite big study in Italy, which I thought was great, of alcoholic hepatitis patients who got fed a high protein diet and then ones who got profoundly protein restricted, and the ones who got the high protein diet actually had faster resolution of their hepatic encephalopathy and got over their acute ALCAT better. So the jury's still out. I think what UNOS says for all of the organ transplantation stuff, if you achieve getting to liver transplant clinic, is that if you're in this chronic severe hepatic encephalopathy category, then that is where you protein restrict people. And it's a moderate protein restriction except for special circumstances. And they try to get people over to a vegetarian diet because a lot of times just changing them over to plant-derived proteins and taking away the meat-derived proteins improves their nitrogen balance enough that they will all of a sudden get better, and that'll be the difference. And then they still get enough protein in their system to maintain their stores so they can get their transplant. Okay, questions? Let's do a case. or two. Okay, so this is a real patient. He was on the 3rd floor for quite a while. And most people probably know him. So this is Mr. A. I guessed at his age. So he's diabetic. He's got end-stage liver disease secondary to NASH. He was never a drinker. Some hypertension and some lipids. And so he shows up somnolent. He's got slurred speech. He's got this continuous shaking tremor. And you sternal rub him and he's like, hey. And then he goes back to sleep. So those are his vitals. What do you guys notice? What catches your eye? Yeah, it's all blur. Okay, so his temp's 102. His heart rate's 105. His pressure's 150/80 roughly. His respiratory rate's in the low 30s, and he's setting 92% on room air. On exam, he's grossly jaundiced. He's got spiders all over his chest. He's got big dilated pupils. He's got this continuous flappy, tremulous thing going on. He's got clonus in his lower extremities. And his lungs are clear, and his heart is tachycardic but regular. His abdomen is huge, it's soft, it's got a fluid wave, and it's exquisitely tender to palpation. And then on lab workup, he's got a white count of 14.5. His hemoglobin's okay at 12. He's with hyponatremic at 134. His K is 3.2. Bicarb's 20. His creatinine's 1.2. His glucose is 420. His liver enzymes are as expected, and his ammonia is 85. Okay, so what stage is his hepatic encephalopathy? You guys can cheat and look at your color graph. So remember, yeah, so he's probably, I would say he's for sure stage 3, and he might be like on the cusp of late stage 3, early stage 4. So he's really somnolent, he's got the clonus, he's got asterixis, he's kind of semi-stuporous in there. Okay, what additional workup do you guys want to do? So the ER was nice enough to draw your basic labs. That's all they did. Now they're calling and saying, we've got this guy for you, and your response is, how about you finish the workup? So yeah, you could certainly get an ABG. What would you be looking for? Yeah, that's a good idea. That's a good idea. Any other thoughts, guys? Anyone want to work up that white count and that fever? Yeah, so what would you want to get? I'm fishing. Okay, how about a chest x-ray? Yes?
Yes.
Okay, how about a UA? Plus or minus a culture. Anything else you might want? Huh?
Differential
On this, yeah, diff. Blood cultures would be good.
This might be all wrong, but how about, did anything show up on a CAT scan of the liver?
It may or may not. I mean, you might see hepatocellular carcinoma. I guess my first question would be, or you might see a portal vein thrombosis. You know, in someone who's got a fever and a leukocytosis, I guess the question would be, do you want to do that first, or do you want to save that in case you don't get anything on your cultures, maybe? Anyone want to tap his belly? It's big, it's distended, it's exquisitely tender. Yeah, so key point, don't forget to tap the belly. And then, do you want to wait for all this stuff to come back, or do you want to treat him? So what do you want to do?
Especially when they're 54. Stick down in NG and give him lactose.
Yes, so he gets his NG and his lactulose, absolutely. Jackie's taken one for the team there. Anyone want to give him some antibiotics? After you get, what kind of antibiotics might you want to give him?
Well, actually, if you think he's septic, though, I think that's what she's saying.
Yeah, so I think you want to give him IV to start with, and you want to cover him pretty broadly, right? Because this guy, he doesn't appear to have a big whopping pneumonia, but he could have urosepsis, he could have pyelo, he could have SBP, he could be bacteremic. Yeah.
How long
Anyone-
has he been sick?
Oh,
Did he have all
well,
of that?
no. He's not too sure.
Not long.
His wife thinks he's been a little worse than normal for a couple days. But you know, liver disease folks are functionally immunosuppressed, right? Anyone want to treat his glucose of 420?
Wouldn't you
Okay.
need an in-depth history on this guy?
Oh, you would. But for argument's sake, we were just going to pass on. But yes, you would. You would want to get a real history. So I would call him stage 3, middle, late stage 3. You guys agree? So he gets an infectious workup, plus other things. He gets his insulin, he gets his IV fluids because he's salmon septic, whether he's hypotensive. We're going to replace that low potassium. The insulin is either sub-Q or a drip, depending on how he does, right? We'll give him his lactulose, probably down an NG tube. Then he gets his empiric antibiotics. Okay, so then you wait and you get some workup back. So your chest x-ray looks pretty good. He's got clear lung fields. They're shrunk because he's got poor inspiratory effort from his mental status. So his UA is remarkably negative except for the bilirubin that I didn't put on there. And so then he gets a paracentesis, and that's his acidic fluid has 680 white cells in it, 95% of which are neutrophils. Few red cells, really low protein, and his gram stain has white cells but no organisms. So what's your diagnosis? Anyone?
So that's not normal, I can tell you.
Normal.
So we could
2 to 5 white cells, 2 to 5 red cells.
So we could pimp out the pharmacists over here who would know this. Carol's like, I want to hide. So this guy meets criteria to formally diagnose spontaneous bacterial peritonitis based on his cell count. You have to have more than 250 neutrophils, even if your gram stain's negative. So he has SBP till proven otherwise. Okay, so the next day, you've done a good job resuscitating him. You've given some fluid. His pressure's in the 140s over 70s. His heart rate's down in the 80s now. His Tmax was just over 100, so his fever curve's coming down. Statting a little better on 2 liters. And now he's more alert. And he's irritable, and he's having this intermittent monoclonic jerking. And he's still got his asterixis, and his abdomen is still big and distended, but maybe it's a little less tender. Right, and the night shift RN informs you that the patient's had 8 liquid bowel movements that are running off the bed.
Now has a rectal tube.
Right, and so then he's got some labs, and his glucose is down to 310, his white count's 10, and his K is still 3 because he's had all this diarrhea. All right, so what stage hepatic encephalopathy does he have now? Well, I think you could argue that he might be stage 3, but he might be late stage 2 now because now he's not somnolent, he's just being a jerk. And this guy was impressive because he had the most impressive myoclonic jerking. Do any of you remember? He had this like hemiballismic thing going on where he'd like do this whole body twitch, and people were worried that he was having a seizure, and it was just the process of his encephalopathy. Okay, so changes to treatment. So think about so we still don't have any culture data back, so we're still on our broad spectrum antibiotics, but think about the 8 large volume liquid bowel movements that have taxed your night shift nurse and CRNA immensely. Yeah, so you might actually want to cut your lactulose down. Now, if you cut your lactulose down, what do you think about his encephalopathy? So it's better than it was yesterday, but is he back to normal?
I would say you leave the lactulose alone.
Yeah.
Increase and put him on an insulin drip if he isn't already on an insulin drip. Replace his K
Absolutely.
and give him some fluids.
Right, all of those things. And then would you want to add anything else to the lactulose? I mean, would you want to, if you're going to leave it alone, you don't want to increase it, but you still need to help his encephalopathy resolve. Yeah, so this is the time where you add the oral antibiotic. Part of the take home here in a guy like this is that if you can manage his hypovolemia and his electrolyte disturbances, it's nice to leave that lactulose dose alone while he's recovering. This particular patient, we cut him back too acutely because he had a ton of diarrhea, and then 12 hours later, he was like comatose and had no gag. So we had to ramp it back up again.
Remember, we always have rectal tubes.
Yes. You notice he got a rectal tube.
We need to get them ordered on the floor,
It might be
so they're
nice
not
if
charged
the-
to my
if
unit,
the
because they're
floor
about
nurse can do 'em on the floor.
$400.
They're not a lot of work.
No, they're easy to use, they're just expensive.
Okay, so now when they're doing it, they're charging them to you.
Oh, are they? Oh, yeah, we need to fix that, because I asked
It might be nice.
for a
Okay.
lot of those to be put in.
Okay.
Yeah, so he gets a rectal tube. Hey, we're not going to talk about the study they did on prison inmates with Hep C, where they did ammonia enemas on them.
Ouch.
And then they gave them lactulose to see if they would clear. Yeah. Okay, so now it's hospital day number 5, and he's recovered, and he's on appropriate treatment, and his wife says, wow, you know, he looks great. He's back to his old self. He's answering all questions appropriately. And your night shift nurse tells you, thankfully, that he only had 3 large BMs in the last 24 hours on his existing lactulose and rifaximin dose. So what would you send him home on? So I would send him home on exactly that, and at exactly that dosing. So if he's in that target 2 to 3, 2 to 4 bowel movements, his mental status is clear at that point. He's looking good. So send him home on both, because he's the guy who wasn't going to handle just lactulose alone. Okay, so in summary, I won't subject you to other cases because I figured we'd went too
What
long.
was his final diagnosis?
So he did have spontaneous bacterial peritonitis. I just never bothered. I couldn't remember what organism it was. So, but yes, you treated him for that and it improved. Okay, so in summary.
How did he get peritonitis?
It just happens
Yeah.
spontaneously, that's why it's called spontaneous bacterial
There
peritonitis.
wasn't any.
They're immunocompromised.
But there wasn't any
No, usually
leak
not.
in the gut.
Nothing inciting, it just happens.
Well, folks with end-stage liver disease have ongoing increased gut translocation of flora, like all the time. So they're sort of like that intubated patient who's post-op, who's been NPO for frickin' forever, and they haven't had a tube feed in 10 days, and you're worried about them, translocating some gut flora. Liver patients do that all the time, and that's actually one of the theories of why they get encephalopathic or why they have chronically low blood pressures, is because they have all this sort of low-dose endotoxin floating around in their bloodstream all the time. So it just can happen spontaneously. So in summary, hepatic encephalopathy, reversible syndrome of neuropsychiatric changes.